Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Daryl Todd, Chief Strategy Officer at Kalderos. Daryl, welcome to the show.
Thanks for having me, Matt. Appreciate it.
So, Daryl, what I always like to do before getting into the main part of my conversation is to give my guests a chance to provide more of an introduction in terms of who they are and what they do. So, Daryl, the floor is yours.
Oh, thanks, Matt. My name is Daryl Todd. I am the Chief Strategy Officer at Kalderos. Kalderos is a technology company in the healthcare space, and it is on a mission to eliminate waste in the drug pricing programs. In doing that, it should enable greater innovation and more patient access to therapies.
So, also, I'm always interested to know, what first got you into healthcare? So, kind of just thinking back through your career, what was it that drew you into this industry?
Sure. Back in the 1990s, I guess I should say I'm a lawyer by training. And in the 1990s, I joined the New Jersey Department of Health and Senior Services as a legal specialist. And that was the game changer for me. I was just so fascinated by the details and the complexity in some of the healthcare programs. And I remember thinking at the time, it's going to take me a long time to really understand the complexity of healthcare. And it certainly has.
Yeah, no, I think that's a pretty fair statement. I know as I was getting into healthcare, and especially, also being on the legal side of it, was, told very early on, the moment you feel comfortable and think you know the answers is probably when you should stop practicing in the area because you're overlooking something.
That's great advice.
So, Daryl, I know you kind of mentioned that you focus on kind of drug pricing programs. So when you refer to drug pricing programs, what do you actually mean?
Well, it's interesting, Matt. The government regulates manufacturers and specifically drug pricing through its safety net programs. So through the Medicaid program, through the Medicare program, and also through this other interesting program called the 340B program. They all sort of operate and are designed to help low-income patients and help sort of the safety net, the elderly in the Medicare program, access medicines and services at lower cost.
So if that's the aim of those programs, just kind of thinking broadly, how successful are they in achieving that goal?
Well, they are successful in actually lowering some of the prices, but it's sort of a zero-sum game. The commercial marketplaces are generally covering some of those costs, and that's sometimes you'll hear that described as cost shifting in the healthcare marketplace. The way the government does that through the Medicaid and Medicare programs are by mandating certain prices, particularly in the Medicaid program and the 340B program, that the government will come in and say that you really have to give your lowest commercial prices to Medicare and 340B. And that's designed by statute. And I can give you a little bit of history on that if that's helpful.
Yeah, no, that would be great. Because I was going to say, you're kind of talking about these programs, but I think, kind of understanding the context of, how they came about by statute, and then, maybe some of the experience so far of the real world application, since we all know that the statutes don't usually end up producing the anticipated results when the language is being drafted.
Yeah, that's absolutely the case, Matt. And if you have to go way back to the 1980s. So, Medicare and the Medicaid programs were sort of in their infancy at that period of time. And essentially, the Medicaid program, the government decided in working with the states that they should require manufacturers to support the safety net patients by giving the lowest price to those Medicaid patients. And the way they did that is by passing a law in 1990. Before that, it was an unregulated marketplace, and many times manufacturers would have charitable programs, and they would give free product or very low price products to nonprofit hospitals, particularly in the urban areas and low income areas, rural areas throughout the country. So what happened was after 1990 and the Medicaid law passed, the manufacturers had to shut down those programs because under the Medicaid rules, if you were giving free product or very low priced product, you would have to give that same pricing to Medicaid. And so the manufacturers sort of lost the flexibility to work with charitable hospitals, and they started raising their prices as you would sort of in a normal marketplace. And then what happened was there was a response. The hospitals then complained, and they went to Congress and went to Washington and argued really that they were being disadvantaged by the manufacturers. Let me pause there and see if you have any questions on that piece of it.
Yeah, no, I mean, I think that kind of even that early history demonstrates a well-intentioned law, I think, as you were saying, of trying to help increase access for low-income or other patients in need, actually kind of removed a voluntary program that the manufacturers and the rest of the industry had come up with, which I think, as you're starting to allude to, then led to further change.
Absolutely, Matt. And it didn't take long. In 1992, so a mere 2 years later, Congress passed a law that instituted the 340B program. So this was interesting because it was designed to help those very patients that were assisted by the charitable nonprofit hospitals. And essentially what it did is it required manufacturers to give that Medicaid pricing to those nonprofit hospitals, but they did it through a different mechanism. They allowed, at that time, the wholesalers, which were the entity at the time that was mainly responsible for differentiating pricing. Again, Matt, I'm going back to like the 90s where managed care was in its infancy, and so most of the differential in pricing was handled by wholesalers in what's called sort of the chargeback system. So they would, for those pharmacies and hospitals that really had large market share, they were able to negotiate better pricing through wholesalers. So wholesalers developed this business of being able to differentiate pricing by customer. And that became really the default vehicle for the 340B program. And it still is actually the default method even today, even though managed care has sort of developed more sophisticated ways to look at and manage utilization.
So kind of, if that's kind of how the program was originally implemented and rolled out, how if at all has it evolved over time from 92 to now, I guess 32 years later, which hopefully my off the cuff math is accurate there. But that's a pretty long time for a program to gain a lot of experience, and with positives and probably warts along the road as well.
Yes. No, absolutely. It's stayed in that same basic structure for the most part. There are a couple minor exceptions, but wholesalers still handle the vast majority of 340B utilization. And as it's evolved and as the government pricing programs have become more sophisticated, it has sort of shown how difficult it may be for wholesalers to sort of manage the program, if that makes sense.
Maybe getting to a different piece of it, but it's, I think you said that it was targeted at benefiting nonprofit hospitals. So is that still the case, or is it, and is that true for any location that a hospital might be in? I'm kind of thinking urban or rural, or I guess maybe in between. Or is it more of a geographic targeting at this point?
So it's a great question, Matt, because it has followed a general path of government programs and has expanded throughout the years. So back in the early 90s, it was really focused on the nonprofit hospitals, and then it's grown beyond that. The Obamacare Act, the ACA, has increased the number of facilities that could participate in the program. And also the program has expanded beyond the geographic footprint of the hospitals. And if I may, I can explain that a little bit.
Oh, no, that would be great. I think, any detail and kind of explanation you can provide on how 340B works in reality, I think is great, because it's my sense is, and, this is not an area that I have delved into very much, but I've seen a number of headlines about 340B, especially in the past few years. And kind of my gut reaction, especially when it comes to healthcare, is if there's a headline about it, then it's missing 99.9% of the nuance to the issue.
Yeah, absolutely. And it's such a complex program, so it's really easy to miss. Not blaming anybody. It can be difficult. But what happened in the early 90s sort of began to set the tone for the expansion. So, as I mentioned before, the law was passed in 1992, and then what's called covered entities. They're essentially the hospitals and other clinics that sort of qualify as 340B entities. They call them covered entities. Just a couple of years into the program, there were some hospitals that complained that they weren't getting the full benefit of the 340B program. So an important thing to recognize is, since this program was designed to help a low-income population, it was designed to help just in the outpatient setting. So interestingly, hospitals buy medication for their inpatients and for their outpatients as well. But the favorable pricing was limited just to the outpatient setting. So some hospitals that did not have outpatient pharmacies, but yet could qualify under the program, were not able to benefit. So they went to the regulating entity, which is called HRSA, the Health Resource and Services Administration, and argued that they're not getting the benefit and they should. So in 1996, HRSA ended up saying, well, look, if you're a covered entity and you don't have an outpatient pharmacy, you can create a contract with an external pharmacy. They called and still call these entities contract pharmacies. And they can essentially provide services and meet within your eligibility. What ended up happening is the ACA in 2010 really exploded the rules regarding contract pharmacies. What they essentially said is that not only may hospitals that don't have a contract pharmacy establish one through contract, they also said that they could establish as many of those contract pharmacies as they want. And then they went on to say, as a matter of fact, even if you have an outpatient pharmacy, you can go ahead and establish contract pharmacies with other entities. And that was in 2010. Where we are today on this issue is that many of the large pharmacies, the national footprint pharmacies, are the pharmacies that are the contracts. And as you may guess, Matt, like it's a marketplace where size can determine the relative split of the discount amounts. And so what you have these big retail pharmacies, some connected with PBMs, that have been able to negotiate a lot of that discount. And what that's tended to do is it's a drift from the nonprofit hospitals to the for-profit pharmacy chains. So here, like you had mentioned earlier, right, sometimes the rules and the laws result in some unintended consequences. This is a great example of that. A program that was designed to help low-income patients in particular areas. Those funds are now shifted to contract pharmacies that are huge retail institutions and connected affiliates of PBMs as well.
Yeah, no, and I think that's very helpful, because I think it kind of gives a little bit more color behind, what, as I said, my very surface level awareness is, which is that there are concerns that the intended beneficiaries aren't actually the real beneficiaries of the program. And for those of you just joining, I'm talking about Daryl Todd from Kalderos, and we're talking about the 340B program. And Daryl's been doing a fantastic job of providing the history and kind of getting into where it stands now. So kind of, Daryl, kind of picking up on what you were just talking about, where on that contract pharmacy side, the bigger pharmacies that I suspect most people would know the names are arguably taking it over to some degree. So kind of looking at the state of 340B now, and kind of having all that experience and seeing what happened after, I think you said one of the bigger, more recent changes was through the ACA, a little over a decade ago. Kind of what are the perceptions of the 340B program currently, and what are the concerns about how it might be missing the mark in terms of the intended aim of the benefit that it's supposed to provide?
It's a great question, Matt, because if you ask the two key constituencies, so manufacturers and covered entities, they would both probably admit that the program's not working as intended. The manufacturers feel that the contract pharmacies have expanded the program beyond their limits, and the covered entities, the hospitals, most of them will say, a lot of the negative attention in the 340B space is from a couple bad actors that are out there. The minority, the very small minority of participants that are playing fast and loose with the rules.
So kind of thinking about that perspective, are there current discussions around building in new protections or modifying the program to kind of help address some of those concerns?
Absolutely. There's a lot of attention on this very issue in the 340B space, the sustainability. Most of the participants recognize that the original intent of the program to help the low income patients that have to seek their care in emergency rooms and so forth, that they really should continue to benefit from the program, or I should say, should benefit from the program. And there's a lot of activity within Congress, within Capitol Hill these days, to sort of address the issues and try to tailor the program to meet its intended purpose.
And kind of also thinking about it, because as you kind of teed up some of the state around the concerns, I think you said the manufacturers and the covered entities are, kind of identifying and recognizing what might be some of the friction points. So while waiting for Congress or the agencies to, enact a new statute or modify the regulations, is the industry taking any steps to kind of self-regulate it and self-police? And I guess I'll pause there and see what might be happening from the industry perspective.
Yes. No, thanks, Matt. I mean, exactly. I think there's a sense that the problem is now, and there's no need to necessarily wait for Congress. I mean, ultimately, Congress will act and deliver some clarity on some of the key areas of dispute. But I guess where industry can really spend its time, and what we do at Kalderos, is thinking about how our technology can provide transparency. And if we can provide transparency between the two key stakeholders, manufacturers and covered entities, then we can start to develop trust among the covered entities and the manufacturers. And in doing that, we can essentially help to assure a meeting of the minds, as they say, with respect to the facts around a particular claim. A lot of the disputes right now, Matt, are that going back to the wholesaler channel for a second. Wholesalers weren't put in place, and they don't do business with this idea of they're going to create a system that's designed to drive compliance on claims. Wholesalers are about filling orders, and so to expect them to also scrutinize claims to determine whether or not a patient is eligible is probably asking too much. Rather, we're definitely at a point where these government pricing programs, 340B included, but others as well, require manufacturers to determine at the patient level, at the unit level of product, what price that patient should be paying, and what price the government program should expect from that utilization. And so we have sort of this convergence of two things. You have the Inflation Reduction Act from a couple years ago that are advancing the requirements on manufacturers, and at the same time, you have the opportunity to have technology put in place to make sure that adjudication is done at that level of specificity per patient, per unit, per product, if that makes sense.
No, it does. And that seems like it goes back to that initial point you made around the transparency. So as you're thinking about transparency to help drive insight into that really granular level of per unit cost, what areas of transparency are most important to help fuel a better understanding of what it will take to achieve those goals?
Yes, no, that's a great question. Essentially, manufacturers are required to understand at a very specific level what's happening with the patient. So, a lot of times, to adjudicate and to make the right price, a manufacturer will base its discount on the eligibility of the covered entity as a hospital. Under the 340B program, a patient has to be an eligible patient. A patient is eligible only if they're a patient of the covered entity. Now, there's a lot of confusion and a lot of litigation around what that definition of patient is. But at its core, there needs to be some level of connection, and manufacturers need to see that. The other thing is the payer itself. The Inflation Reduction Act is going to require very shortly for manufacturers to not only understand whether or not the utilization qualifies for 340B payment, but just to add another layer of complexity. If it's a Medicare patient and the product falls within the what they call the maximum fair price program, then the manufacturer is going to have to figure out which price is lower, the 340B price or the maximum fair price, and be able to adjudicate the difference. And they're going to have to do that within about 2 weeks. So it's a game changer in terms of government pricing programs, because it really puts the manufacturer in the position of having to understand that level of detail. And the only way you can really do it is very quickly after the adjudication process, and the covered entity and the manufacturer can work together to understand all those data elements.
It's kind of, given what you just said of the requirement to work together, that seems like it then goes to the common theme of trust between different players that maybe historically have not been as well aligned as would be desired. What do you think might be required to help actually create an environment where that trust can grow and develop in a positive manner, so that way both sides can recognize, and I say both sides, even though it's probably multiple sides, and because it seems like very rarely are things binary in healthcare. But what's it going to take to foster that environment of trust where all these different players get comfortable working in the same direction?
Great question. The covered entities and the manufacturers both have compliance obligations around these pricing programs. And so what you need is an understanding of the common set of facts. And so what we're working on at Kalderos is that very platform, a platform where the covered entities can submit their data and the manufacturers can review that data, and both sides have full access. And that's a game changer as well. So, Matt, as you know, with your legal background, disputes can be either around the facts of the situation or about what something means from a legal standard perspective. And we'll leave it to Congress and the courts to figure out those legal standards. But we tend to find that most of the disputes are around the facts. Have we captured the important data elements that I'd mentioned? And do we agree that those are the actual data elements that reflect the patient utilization? And if we have an open and accessible platform, that should go a long way in not just increasing the transparency, but the trust among the participants as well.
Yeah, no, I think that's a great point. As you said, if you can get alignment on the facts and everyone can agree and recognize, that the set of information is the accurate one and what you should be working from, that goes a long way towards being able to reach a common understanding, because then you're not either intentionally or unintentionally assuming or working from completely different starting points.
Absolutely. That's absolutely the case.
So, Daryl, believe it or not, we're already almost at the end of our time. So I'm going to ask one concluding question. We've talked a lot about kind of the intricacies and the nuances of 340B, and I think unfortunately strayed a little bit more on the negative side. So my final question is, what's one of the most unexpected benefits that you've observed out of the 340B program?
I could tell you, Matt, what I'm most excited about, and that is if we can, not just with Kalderos' technology that I mentioned should drive to a common understanding of the facts, but also clarity through the courts and Congress. If we can do that, we'll be able, I think, to capture the data that will allow us, allow the 340B program to go back to its roots. And so right now, believe it or not, the patients are not required to benefit at the point of sale. So if you think about the scale of this program, this 340B program, this is going to sound negative, but I swear I'm optimistic about this. The 340B program requires $60 billion of discounts through the system. Of that, the law doesn't require patients to benefit at all. The 340B law doesn't. So with the data elements that we can generate, then I think we can look more closely on what's happening to patients at the point of sale. And I think covered entities want these data elements as well to help their patients, to be able to help their patients at the point of sale with their co-payments or their out-of-pocket responsibilities. So I see that as a real positive benefit that can happen in the near future.
No, I think it'll be very exciting to track that, and like you, hope we can get there. But as I said, believe it or not, we are already out of time. I want to thank my guest Daryl Todd for a great conversation today.
Matt, thank you so much. I really appreciate your time, and it was great. Great opportunity. Thank you.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.